Thanks, Jim. It's a pleasure to be here. And I can say again, because this is actually the third time I've been to Erlanger. So it's either you like me or I'm cheap. I don't know which. A little of both. Okay, so I want to talk about the management from a nephrologist perspective and what we're doing today. And then, in the question period, we can talk about what we're doing in the future. So I'm going to start with a case. And this is just generic. A young Hispanic female was diagnosed with lupus about 4 months ago. Clinical manifestations at that time were rash, pleurisy, an ANA, and a double-stranded DNA. Urinalysis at that time was unremarkable, which is not unusual. Serum creatinine was normal. She really was treated with a very modest dose of prednisone, had good symptomatic resolution. She didn't tolerate the steroids very much, and she tapered the prednisone herself, which is often what we see. We saw her in follow-up, and she had new pedal edema. Urinalysis showed blood and large protein on the dipstick, and there were several acanthocytes and one white cell cast on microscopic examination. Her serum creatinine was 1, complement levels were low, albumin was low, and a spot urine protein to creatinine ratio was 5. A kidney biopsy was done. So let's talk a little bit about the diagnosis of lupus from your perspective, since we're all internists in the room. And this is sort of my very easy schematic panel of evaluating the lupus patient for lupus nephritis. So testing for lupus nephritis is indicated at the very first presentation of, I guess this is how I'll do the pointing, right? There's no pointer. Testing for lupus nephritis is indicated at the first presentation of lupus, and then whenever you have a suspicion of a lupus flare. Very simple screening panel, just a serum creatinine and a urinalysis, and you should do a dipstick and a sediment. So obviously what we're looking for is evidence of abnormal proteinuria on the sediment. And remember, on the dipstick, the proteinuria depends on the concentration of the urine. So anytime you see a dipstick proteinuria of 2+ or more with any specific gravity, or a dipstick protein of 1+, but the urine is very dilute, that's something to be concerned about. And then we look at the sediment for acanthocytes, and I'll tell you what those are in a minute, red cell or white cell casts, and white cell casts in the absence of infection. We also like to look for evidence of decreased GFR. So serum creatinine above the upper limit of normal certainly would raise your attention. But remember that most of these patients are young women. They don't have large muscle mass, and so what we think is a normal serum creatinine, for example, a serum creatinine in this patient of 1, may actually be very abnormal, and her baseline serum creatinine is probably 0.6 to 0.7, as we knew from 4 months previously, and that is a significant change in her GFR, but that often goes unnoticed because it seems like it's in the normal range from your laboratory. And then the abnormal serum creatinine has to be attributable to lupus and not other causes. So if a patient has proteinuria more than 500 milligrams a day or evidence of decreased GFR, we do a kidney biopsy. And I'm going to try and justify why we do a kidney biopsy in a few minutes. So here's one of the things you need to think about. Lupus patients are often being treated with a lot of different medications, not the least of which is immunosuppression. So impaired renal function in the lupus patient is not always due to lupus nephritis. And I think that's where people make a mistake and then may increase the immunosuppression. So you need to rule out infection, number one. Hypotension, volume depletion. A lot of these patients get a lot of tests, so they're exposed to nephrotoxic drugs, hemolysis, thrombosis, cardiac failure. As you know, lupus can affect many of the organ systems, and so all of these other manifestations can impact on the kidney. And then, of course, there can be non-lupus glomerular diseases, and we'll talk about that a little bit as well. Not every patient with lupus nephritis, or with lupus, develops lupus nephritis. And then, of course, in the rheumatology world, commonly prescribed drugs are nonsteroidals, which are toxic to the kidneys, antibiotics, which can cause interstitial nephritis, and many of these patients are on renal angiotensin-aldosterone system antagonists. Okay. In looking at the prevalence of renal abnormalities in lupus nephritis, everybody who has lupus nephritis has proteinuria. And that's sort of a self-fulfilling prophecy because we define lupus nephritis by proteinuria. So everybody has to have it. Now, if you wanted to push the question and say, well, what about any patient with lupus? There's an entity called silent lupus, and we really don't know the extent of it. But if you look at autopsy studies of patients with lupus, almost everyone with lupus, even though they may not have clinical manifestations, has immune complex deposition in the kidneys. My guess, and this is just my opinion, is that almost everybody with lupus actually does have kidney involvement. Whether it reaches clinical consciousness is really hard to say, and why it does in some patients and not in others is not clear. But certainly in the early stages of lupus nephritis, it can be clinically silent. Nephrotic syndrome in about half the patients, microscopic hematuria in most of the patients, but not all of the patients. But note, macroscopic hematuria in very few patients. So if you have macroscopic hematuria in a lupus patient, think of other things. Now, red cell casts and cellular casts we like to see, but we have to handle the urine appropriately. We can't let it sit around. We like to get a very concentrated specimen, a first morning void, etc. So you may actually miss red cell casts. This is another interesting number. Impaired kidney function, you see a wide range here. And I think part of the problem is that for most of these patients, they were young and healthy individuals prior to coming into your office with issues with lupus, and so they don't often have a baseline serum creatinine. So if we knew their serum creatinine was 0.5 and they came into you with a serum creatinine of 0.8, you would realize over time that something has changed. And so I think renal impairment is probably much higher in lupus as its presentation than the serum creatinine would dictate. And then some of these other abnormalities are seen less frequently. What I like to show the residents and fellows is the urinalysis. Even at our institution, which is a center for glomerular diseases, I was told that they're taking my microscope privileges away because I'm not CLIA certified, and the person in the lab who has a high school diploma that runs the urinalysis machine is. So I just lock the microscope up and we have the key and they don't. But anyway, I think urinalysis is something that's really important for nephrologists to do, and we're losing that in our fellowship. But I'll just throw this out there for you because I think it's very interesting. So these are dysmorphic red blood cells, but they're a specific type of dysmorphic red blood cell. They're called acanthocytes. And what you see here is sort of the normal red blood cell shape, a biconcave disc with a bleb. And this bleb occurs probably as the red blood cell moves through the glomerular basement membrane and gets damaged. And these are very, very specific for glomerular bleeding. And you see them in glomerulonephritis. The problem is the sensitivity is a little bit low, and often you have to search for these. This is a typical red blood cell cast, and if you see this, for your purposes, that means glomerular hematuria and glomerulonephritis. This is a white blood cell cast, and you can see it's very different than the red blood cell cast. The cells are bigger, there's nuclei, and they're granular. Now, you can have white blood cell casts in the absence of a glomerular disease. It can occur even in pyelonephritis. You look for bacteria. But in the absence of infection, a white blood cell cast should suggest to you inflammation in the renal parenchyma and something to worry about. Now, these are what your textbooks call muddy brown ATN casts, acute tubular necrosis casts. And these are not generally part of lupus nephritis. If you do see them in a patient with lupus, then you have to think about other causes of renal disease in the patients. And of course, the common ones that you all probably know on your consult services will be infections, hypotension after surgery, heart failure, etc. So you can get a lot of mileage out of looking at the patient's urine. I include this because it's fun and you don't often get to see these things. Um, I have our pathologists take interesting pictures, but what I think is sort of will solidify in your mind, this is an electron micrograph of a kidney biopsy of somebody with lupus. And you see here, these red blood cells are within the capillary, and they're sort of smooth in appearance, and they look normal for a red blood cell under electron microscopy. But you can see here that these red blood cells look pretty weird, and they've actually escaped the glomerular capillary and they're in Bowman's space. And what these red blood cells look like when they plop out into the urine are the acanthocytes. And this is how we think acanthocytes are formed. This is a kidney biopsy, and if you look at the tubulointerstitium, not just the glomeruli, because it's important to consider the tubulointerstitium, you can actually see red blood cell casts in the tubules. And of course, if you pee them out, then they look like this in the urine. So this is what it looks like in the kidney, and I suggest that when you do have a patient with lupus, go down to your nephropathologist and see the biopsy with them. Okay, I want to talk about assessing renal function in patients in general and patients with lupus. So as all of you know, and probably on your laboratories here, you get EGFRs, which tell you what the renal function is. And we'll talk about that in a minute. We are very much at Ohio State not in favor of EGFRs, but we realize that's the trend. We think that serial measurement of serum creatinine is a useful way to monitor renal function in lupus nephritis, but you have to understand that serum creatinine can be increased or decreased by conditions that are independent of the GFR. Now, one thing that's really important is tubular secretion can be affected by certain drugs. Most of these patients will be on immunosuppression of some sort, and they'll receive prophylactic sulfa drugs for infection. And trimethoprim can actually affect the tubular secretion, which accounts for about 30% of the excretion of creatinine. And when that happens, patients can have an increase in serum creatinine, and that has absolutely nothing to do with deteriorating renal function in the patient. Similarly, you can have an artificial decrease in serum creatinine if the patient is nephrotic and has hypoalbuminemia. So these are things to watch for because they're very common in patients with lupus. I highlighted this in yellow because this is really something that people seem to overlook. If you give patients high-dose corticosteroids, and we often give high-dose intravenous and then oral corticosteroids in patients with lupus, that affects muscle metabolism. And during the period of time when they're receiving these very high doses, the serum creatinine can go up, and it does not reflect a decrease in the GFR. But what it can do is make you worried that the patient is getting worse and make you want to change therapy very quickly. So that might not be the case. Hold tight. Okay, and then a diet high in cooked meats increases serum creatinine. A vegetarian diet decreases serum creatinine. Let me just talk for one brief second. I'm not going to get into the controversy of EGFR, but it's calculated from estimating equations. As I said, it's routinely reported in almost every laboratory. Please understand that not any of these estimating equations have been validated in a typical lupus population. Okay, these are mostly validated in older people with chronic kidney disease, diabetes, hypertension, etc. Okay, so that's one issue. The other issue is that all of these equations are based on the serum creatinine. So despite what people say, all of the weaknesses of serum creatinine are still inherent in these estimating equations. And finally, the last point is that all of these equations assume that patients of the same age, race, and sex and serum creatinine have the same rate of serum creatinine production. And that simply is not the case. So, again, rely on your clinical judgment and all the other laboratory parameters, not simply one piece of data from your laboratory. Okay, the biopsy conundrum. The kidney biopsy is needed in the diagnosis and management of lupus nephritis. Who thinks that's true? Two, three, okay, a handful of people. The rest are sleeping or, okay, well, Tumlin, because he biopsies normal people. Like, I have to get a biopsy before I go home today. Yeah. So the reason I say this is the worrisome trend that mycophenolate is a drug that takes care of everything in lupus nephritis. And why would you biopsy a patient if you're going to treat with mycophenolate? So I want to just throw a case out for you to try and illustrate my point. A middle-aged Caucasian woman had alopecia, ANA, had double-stranded DNA, low complement levels, and she had antiphospholipid antibodies and a positive lupus anticoagulant. She was in the hospital with acute kidney injury, but it was clearly not due to lupus. Okay, it was sepsis, dehydration. She had a surgery. Her serum creatinine peaked in the 5s and then fell down to 1.2, which I hope all of you realize in the room that's probably not a normal serum creatinine for a woman. She had a pericardial effusion, a drain was placed, and then all of a sudden she was found to have hematuria and proteinuria, about a gram of proteinuria per 24 hours, and a kidney biopsy was done. Anyone want to vote? Tumlin, what do you think? Lupus nephritis? Okay, so this is why this is important, because here you have an expert in glomerular diseases who will be touring the world with us, lecturing on glomerular diseases from the American Society of Nephrology, and this is what the biopsy showed. So she actually had interstitial fibrosis and tubular atrophy, and she had very severe damage of her blood vessels. And she had a lot of sclerotic glomeruli. She had some mesangial hypercellularity and expansion. And when we did immunofluorescence, she had very mild to moderate mesangial IgA. So what this lady actually had was a lupus anticoagulant and a antiphospholipid nephropathy. And you would not have guessed that because she had, as Jim pointed out, a lot of things suggesting very active lupus, systemic lupus. Okay, so you can't tell. And I've summarized this here for you as to why we believe a biopsy is indicated. Not all the kidney disease in a lupus patient is lupus nephritis. About 5%, and this is a hard figure to estimate because we don't biopsy everybody, about 5% of patients will have other glomerular diseases, and the very common ones are minimal change disease and focal segmental glomerulosclerosis. And you'll hear the word lupus podocytopathy. It turns out that diseases of the podocyte, which mimic what we call idiopathic FSGS and idiopathic minimal change disease, occur with a higher frequency in patients with lupus. Nobody knows why, but the treatment of them is different than the treatment of a patient with aggressive proliferative lupus nephritis. The antiphospholipid antibody syndrome, as I just illustrated, occurs with or without lupus and interstitial nephritis, which is actually pretty uncommon in lupus, but it is something that we have to consider. The other reason to do a kidney biopsy is that not all the kidney disease in lupus nephritis needs to be treated aggressively with immunosuppression. So, class 2 lupus nephritis, probably not. And then chronic changes without evidence of inflammation, you don't need to treat aggressively. So you get a lot of information from the kidney biopsy, and I believe it's still required in lupus nephritis. So one of the questions that we're frequently asked is, when would you consider a biopsy? At what level of proteinuria are you worried? And so these are 3 different studies that suggest that you don't need a lot of proteinuria to have very, very active lupus nephritis. So this first study was presented at the ASN that was done in Atlanta in 2013, and I know the paper is getting ready for submission. But they examined renal biopsies in almost 40 patients with lupus, normal kidney function, just some glomerular hematuria. Proteinuria was less than 500 milligrams a day, and all of these were the first presentation of lupus. And I just want to point out here, of those 40 patients, the vast majority had class 3 and 4 lupus nephritis. Okay? This is a study that just came out last year, and this is really, really worrisome. Patients with proteinuria less than 500 milligrams a day in their population, 24% had proliferative lupus nephritis. Okay? What's even more scary is that patients with proteinuria less than 250 milligrams a day, 7% of those patients in their study had proliferative lupus nephritis. So we at Ohio State tend to biopsy a patient if the proteinuria is 500 milligrams or more. This new study suggests that maybe we should go lower. And I'll tell you the truth, we look for an excuse to biopsy a patient who we think might have lupus involvement of the kidney so that we can understand what to do. So just keep that in mind. I know what the textbooks say. They often say a gram, 2 grams. Nobody has a consensus on that. So let's continue with the case. The biopsy was consistent with class 4 plus class 5 lupus nephritis, high activity, low chronicity, and one tiny crescent was seen. So I want to just go over this so all of us in the room are on the same page, because I don't know if you get a chance to look at this. This is class 2 lupus nephritis, and if you're looking here, I think this, okay. So class 2 lupus nephritis clinically has some proteinuria and hematuria, no renal insufficiency, and you do not expect nephrotic syndrome. By light microscopy, you see mesangial expansion and maybe some proliferation. And then in the electron microscopy, you see some electron-dense immune deposits in the mesangium. Okay. This does not require aggressive treatment. Now, is this a harbinger of something to come? It may be, but we don't know that. Generally speaking, for these patients, we just treat with immunosuppression that covers their extrarenal lupus. Okay, the proliferative lupus classes, class 3 and 4, you can see the pathology is quite different. So proteinuria and hematuria are seen almost all the time in these patients, and you can have nephrotic syndrome. You see endocapillary proliferation, and of course I've blocked this off, but here you don't see any open glomerular capillary loops, okay? And with that, you see leukocyte infiltration, you can see crescents, and you can see necrosis of the glomerular capillary walls by light microscopy. These patients are characterized by subendothelial immune complex deposition, often very big immune complexes, and class 3 is less than 50% glomerular involvement. Class 4 is more than 50% glomerular involvement. These patients generally require aggressive immunosuppression, or they will progress on to renal failure very, very quickly. Okay, then we have class 5. Class 5 is the same, at least by appearance, as idiopathic membranous. We call it membranous lupus nephritis. You see, well, it's hard to see here, but these are subepithelial immune complexes. And class 5 is characterized mainly by proteinuria. It's often nephrotic. You sometimes have hematuria, not always. Usually there's no renal insufficiency at the beginning. This is a glomerular basement membrane reaction to immune complexes, and you have growth of the glomerular basement membrane. This is interesting. This is what our patient that we're discussing has. She has subendothelial immune complexes and subepithelial immune complexes in more than 50% of her glomeruli. So she has a combination of class 4 plus class 5. And we do often see that. So membranous plus proliferative. And down here is end stage. So this is class 6 lupus nephritis. Now, if you did this biopsy, a patient might have proteinuria, but they don't have any active disease, and immunosuppressing them won't get you any benefit, so you might not want to subject them to the risks of immunosuppression. Okay, so we told this patient she has lupus nephritis. What should we do? And this will be the treatment of proliferative lupus nephritis. But first I want to discuss the goals of therapy. We want to preserve long-term kidney function. That's what our goal of therapy should be in patients with lupus nephritis, to avoid the need for dialysis or transplantation. The second thing we want to do is to minimize chronic kidney disease. Now, this one is pretty obvious, right? Nobody wants your patient to go on to dialysis. Chronic kidney disease is really important to think about, and we don't often think about it in these acute GNs. Chronic kidney disease increases the risk for cardiovascular mortality and morbidity in patients, And patients with lupus, systemic lupus, already have an increase in cardiovascular morbidity and mortality for their age group, right? These are mostly young women. So let me just show, since this is a general medicine audience, this is the relationship. These are fairly important studies that have come out over the years. This is a relationship between EGFR and cardiovascular events. And here you can see the EGFR is listed, and greater than 60 for some reason is considered okay. Now, nobody in this audience probably wants an EGFR of 61. And those of us who have normal, we know they're in the 100 range or more. But just for the purposes of this study, an EGFR in your laboratory is probably reported as greater than 60 without quantification beyond that, or less than 60, and then you get a number. And that's considered a risk of 1. When you have a very mild impairment of EGFR, your risk increases for any cardiovascular event. And this is an independent risk factor because these hazard ratios were adjusted for all the things you think one should adjust a hazard ratio for when you're considering cardiovascular mortality. And look at the increase in cardiovascular disease as the GFR plummets. Okay, so CKD is a big deal. This is another way to look at it. If you look at CKD 1 or 2, this study looked at the prevalence of cardiovascular disease in different stages of chronic kidney disease. The stages of chronic kidney disease are listed here, and I don't want to go over them. What I want to point out is stage 1 is some abnormality of the renal parenchyma with normal EGFR. I will challenge you to show that anybody who's had lupus is not left with some abnormality of the renal parenchyma after the disease heals. Stage 2 is a very mild decrease in EGFR, 60 to 89. And so in the purple is stage 1 and 2 CKD. Increased risk, this is the control, the blue, increased risk of MI, peripheral vascular disease, and stroke or ischemic events. So this is a big deal, and we have no way of actually figuring out at the present time the amount of CKD residual in the patients with lupus nephritis. So we want to sort of prevent that and certainly prevent from progressing. I think we're losing sight of these goals in favor of short-term endpoints of complete and partial renal response. And I think that's being dictated to a large extent by clinical trials, mainly designed by pharma, although Dr. Tumlin and I are trying to work on that, in which the cost of the trial is so prohibitive, we have to have short-term endpoints, otherwise you can't do the trial. So, this is the general scheme of how we treat lupus nephritis today. There's an initial therapy. We give it for 3 to 6 months. The patient hopefully stabilizes, gets better, or remits. And then they are put on maintenance therapy, and if after maybe a couple years they're in complete remission, then you wait a little longer and you consider tapering off therapy. If they're in partial remission, you may need to consider indefinite therapy. I'm not agreeing with all of this. I'm just showing you what the current trend is. And then if a patient gets worse, you choose a different initial therapy. Okay. Here's our current definition of complete renal response. And as you can see here, we don't have one. These are recent trials, or the first one is the American College of Rheumatology. And you can see that there's similarities amongst these definitions, but each one is a little bit different. And they have different protein to creatinine ratios that you have to achieve. They have different changes in GFR that's acceptable. Some of them use urinalysis, some of them don't. Some of them require glucocorticoids to be tapered. This is really sort of interesting. Nobody requires the complete renal response to be verified over time. And I think that's an unfortunate mistake. So we don't know which of these criteria, if any, actually portend good long-term renal function many years down the road, which is really what we want to achieve. So to address this question, we looked at two studies that were done in Europe. Now, please understand this is a post hoc analysis, and all the things that go along with post hoc problems is part of this. But we re-examined the low-dose cyclophosphamide study, which was called Lupus, and the MAINTAIN study, which looked at patients put on maintenance with azathioprine or MMF. And these patients had a minimum of 7 years of follow-up after entry to that study. We looked at proteinuria, serum creatinine, and hematuria because these are kind of the things that we want to look at in today's complete and partial response endpoint era. Okay, and then we defined good long-term kidney function, so kidney function after 7 years or more of less than or equal to 1 milligram per DL creatinine. Now, we can argue about that. But I think most of us would be happy if our long-term patients with lupus nephritis maintained a creatinine of 1. Okay, and then we assess diagnostic performance of these various variables using receiver operating characteristic curves. The idea was to maximize the sum of sensitivity and specificity for the outcome, and we determined optimal cut points for each of these parameters, and then looked at positive and negative predictive value. And I'm going to just summarize everything here. Because the paper is too complex to go through in this short time. I've highlighted proteinuria. It turns out that both in the ELANT, the Lupus Nephritis trial, and the MAINTAIN trial, the one variable at the end of 1 year of follow-up that best predicted good long-term renal function was actually proteinuria less than 0.8 gram per day or proteinuria less than 0.7 gram per day. Okay, so this is not consistent with complete and partial responses they're currently defined in most settings. If you added serum creatinine less than 1 at 1 year, so these patients come in the trial, they have flaring lupus, you treat them, and they achieve a proteinuria less than 0.8 grams per day. Let's just say less than 0.7 grams per day. If you add a normalization of the creatinine to that, it does not improve, it doesn't detract from, but it doesn't improve the sensitivity or specificity. If you add red blood cells, which the rheumatologists love to count, if you add red blood cells, not only doesn't it help, it actually detracts from the sum of sensitivity and specificity. So here's the positive predictive value for a proteinuria level less than 0.7 to 0.8 gram per day. You see the positive predictive value is pretty good. The negative predictive value is pretty poor. So let me try and interpret this for you. Here's the considerations. First of all, we did this using a Northern European Caucasian predominant population. And so this has to be reproduced in patients of other ethnicities and races. Okay, so that's number one. This is not ready for prime time. I don't think this applies to treatments that decrease proteinuria potentially by non-immune mechanisms, for example, the calcineurin inhibitors. So this will confound the interpretation of proteinuria. These results may not apply to class 5 by itself because none of these patients were pure class 5. And this is important. If you achieve the target proteinuria after a year, so you come in with 3 grams of proteinuria, you come down to 0.5, you're going to do well. Okay, that's what this tells us if you're a white European. However, even patients who didn't achieve that level actually did well over time because the negative predictive value wasn't so hot. So this is not the perfect test, but it sure makes us think that maybe complete and partial response as they're currently defined are not correct. So stay tuned. We're currently working with the Kidney Health Initiative to come up with better clinical trial responses. Okay, what about the treatment of lupus nephritis? This is the nonspecific treatment of lupus nephritis, and I'm going to just say this because there are a lot of data here. We as nephrologists have not often embraced the use of Plaquenil. The rheumatologists have been using Plaquenil or the antimalarials for a long time. And studies are coming out, and these are very compelling studies that suggest that even though Plaquenil tends to take the edge off of the arthritis of systemic lupus, etc., if you withdraw Plaquenil. This was the Canadian withdrawal study. Patients actually flared, and they had a lot of severe renal flares. In this particular population, they looked at patients who were on antimalarials and the percentage of who developed end-stage renal disease and their mortality. And the patients who were treated with antimalarials developed less end-stage renal disease and had a higher survival. And that's actually what these other studies are showing, including this very recent one that came out in the journal Medicine, which shows that the risk factor is diminished for renal involvement if you keep a patient on an antimalarial. So if a patient can take Plaquenil or hydroxychloroquine, they should. You know, they need eye examinations, et cetera, all the things that go along with the drug. Okay, this is my sort of schematic, and I know Jim is very critical of my slide format and the way I design slides, but I had a lot of information to get on here. So if you have, this is a mashup. I know the young people in the audience know what a mashup is. My daughters had to tell me. I put everything together that exists. You usually do that with music, but I do it with science. And of these American College of Rheumatology, KDIGO, and the European Congress's guidelines. So you have proliferative lupus nephritis. If it's really severe, and we can debate what severe means, patients will get IV methylprednisolone at some dose for 3 days generally, and then very high doses of oral prednisone. If the patient is less severe, maybe you'll skip the methylprednisolone and put them on high doses of oral prednisone. Jim doesn't. I do. I don't know who's right, but it's me. No. I think we use way too much steroid in this country. In Europe, they don't use 1 milligram per kilo per day. They generally start out at 0.6 milligram per kilo per day. And we're going to talk about steroids in a minute. Then, what are the actual additional therapies that you add on to lupus for lupus treatment? You can add on cyclophosphamide, or MMF. So literally, there's 2 different dosing regimens of intravenous cyclophosphamide, which is low dose, that's the Euro-Lupus protocol, high dose, which is the NIH protocol, or MMF. After all these years, this is what we're still doing. And I'm not going to discuss each of these protocols. They're all written out in these guidelines. But it just shows you that we haven't made much progress in the treatment of lupus nephritis. Then you go to a maintenance phase. We do have some data on maintenance. Maintenance with MMF, in general, seems to be favorable if the patient can take MMF. You can use maintenance with azathioprine if the patient gets pregnant. Don't use MMF with pregnancy, obviously. And then if the patient can't take either of those drugs, a calcineurin inhibitor is possible as well. Okay, so let's get back to this patient. She had lupus nephritis. We started her on an antimalarial. We controlled her blood pressure, dietary restrictions, etc. And then we recommended high-dose prednisone and MMF. She said no. She's not going to take steroids. When she was on a low dose of steroids, she felt terrible. She was in school. She couldn't concentrate, gained weight, acne, the whole 9 yards. So what should we do? Treat with MMF alone? Treat with cyclophosphamide alone? Or discuss a steroid-sparing protocol? Who wants to? I can pick on Tumlin because I know him. What do you want to do? Okay. So, but she says no to you. She doesn't want to do that. And she doesn't also want to do the steroids. So, one of the things that's a pet peeve of all of us who take care of lupus patients is the amount of steroids we use. Steroids are an excellent anti-inflammatory. They work really well. They cause a lot of problems, as all of you know. This is the Rituximab protocol, which Dr. Tumlin and I are participating in. Its origin is Hammersmith Hospital in the UK. And this is their pilot study that got this approved. Biopsy proven class 3 or 4 or 5 lupus nephritis, patients not on steroids. They excluded rapidly progressive GN. The patients got 2 doses of rituximab, and with each dose of rituximab, 500 milligrams of methylprednisolone on days 1 and 15. Maintenance was then with mycophenolate. Okay, look at this. No oral steroids were used. Okay, this is the distribution of the data. This is the follow-up. I think it's being cut off at the bottom, but this was presented at the ASN within the last year or two. They followed 50 patients, and then 42 of those patients had at least 5 years of follow-up. Here's the ethnic background. You can see that most of these patients are white, and then the other high percentage is Southeast Asian patients. And then they had a pretty good distribution of proliferative lupus nephritis, but a very high and unusual amount of pure class 5, which generally we don't see in our populations here. Here are the data. Complete and partial remissions. So 88% of these patients achieved complete or partial remission on this regimen. And you can see it was pretty good for all the classes, including the proliferative classes. The median time to remission was very similar to what we see using cyclophosphamide. There were 19 renal flares after these 38 patients or 37 patients went into remission. The median time to flare was about 2 years. Again, very consistent with historical standard of care treatment. 80% were managed without oral steroids. This is remarkable because the sort of go-to for a flare is a steroid. And about 70% were retreated with rituximab. So these patients did very well, leading to a steroid-sparing trial that is now almost up and ready to go. So let's finish up the case. The patient eventually agreed to be treated with MMF and steroids. We rapidly tapered, and we started at 0.5 milligram per kilogram per day initially. After 6 months of treatment, the patient's creatinine was 0.9, and her proteinuria had declined to 1 gram a day. Complement levels normalized. After a year, serum creatinine was 0.8. Remember, her baseline, all the way from the beginning of this talk, if you can go back that far, was 0.7. So she's getting near her baseline. Proteinuria was 250 milligram a day. She was feeling well. She had no extrarenal lupus. And then 3 years later, she felt great. She got married. She was considering children. Her creatinine complement levels were normal, and she had a urine protein to creatinine ratio of 0.1. So she's done well. Okay. And I don't disagree with what Dr. Tumlin said. If this was my patient, I probably would have used cyclophosphamide. Okay. But MMF worked in this case, at least for now. What do you recommend now? She wants to have a family. Get rid of MMF. Change immunosuppression to azathioprine. Change immunosuppression to a calcineurin inhibitor. Tell her never to get pregnant, or repeat a kidney biopsy to inform your treatment decision. Jim? Okay, so there's a couple of things. You're wrong, of course, but besides that, I want to make a point. But one thing I do want to, we see a lot of young women who have had lupus and have been told they can never, ever get pregnant. And this is really not a good idea because, you know, having children is really important to many, many people. And so we try very hard to get the patients to the point where they can have a family. So I would say this would be the answer I would think of as the very last alternative ever. Okay, so just keep that in mind. Now, I actually did a segue here because I did want to talk about repeat biopsy. And I want to talk about the duration of maintenance therapy. After a complete remission, it has been suggested that maintenance therapy be continued for at least 1 year before tapering it off if you hit a complete remission by whatever definition. Now, I know who wrote that. It was me in the KDIGO guidelines. And I also know that this is as you evaluate evidence, you know, you have letters and numbers that actually tell you the strength of the evidence and whether it's been done by randomized trials, et cetera. This is like a 10F, okay, which doesn't exist. There are no data, okay? I made this up. I don't want to say I made it up because that sounds really bad. But in the KDIGO guidelines, we're very transparent. We said, this is what we do. There are no data for this. Here are the data. Duration of, and these are all the studies I could find at the time. I wrote this maybe 3 or 4 years ago. Duration of maintenance therapy in 7 randomized controlled trials. The mean duration of therapy was 3.5 years. The median duration was 2 years, and the range was 1.5 to 7 years or forever. Okay, so what I want you to leave here is we are uncertain as to how long to use maintenance therapy in a patient with lupus nephritis. If you talk to many of our rheumatology colleagues, the answer is forever. We try to get them off therapy if at all possible, and we've been successful. But if you were in oncology, you would want to know that the cancer is gone, and we have an organ that we can look at tissue, and we'd like to know if the disease is gone. So let me talk a little bit about rebiopsy to determine the length of maintenance therapy, and this is my last part of this discussion. We did this study with our collaborators in Argentina, where they do serial biopsies, and these are all Hispanic individuals, mostly female, young, according to the following timeline. Biopsy 1, like we do at the time of diagnosis. Biopsy 2, after 6 months of induction therapy. This is not common practice in the United States. Biopsy 3, during maintenance therapy, and these patients had had at least 42 months, almost 4 years of total treatment, and 30 months of clinical inactivity. So by clinical criteria, these patients were in good shape, okay? And they had been treated just like we treat patients in the U.S., NIH cyclophosphamide or mycophenolate, good doses. Maintenance therapy was either mycophenolate at the appropriate dose or azathioprine. So the treatment is the same as what you and I would do currently. This was the clinical course of these patients. Biopsy 1, biopsy 2, and biopsy 3, you see that the serum creatinine improved. The proteinuria went away. These are the averages, as you can tell. Complement C3 and complement C4 got better. These patients did as well as anyone could hope to do with therapy. Okay? This is a graph of the histologic activity at the third biopsy. Remember, this third biopsy was almost 4 years after the start of treatment, 30 months of clinical inactivity. We defined a complete renal response as a normal serum creatinine, so less than 1 in a population predominantly women, and a urine protein less than 500 milligrams a day. A partial response was a stable serum creatinine, so you had to stabilize your GFR, and then you had a urine protein that was greater than 500 milligrams, but less than a gram. Only 44% of complete clinical responders had complete histologic remission. Now, just for those of you who don't do this all the time, the activity index was created by the NIH many, many years ago to give you an idea of active lesions in lupus, so inflammation, necrosis, proliferation, and the chronicity index is scarring. Okay? Here we're talking about the activity index, which summarizes all of the bad things in a kidney biopsy histologically that you don't want to see, because generally as they progress, they lead to scarring of the kidney tissue and loss of renal parenchyma. So only 44% of the complete responders had a histologic complete remission. That's an important number. Now you can say to me, and I'm going to show you why I think this is important. Well, okay, but you know, most of these people, look, they were below 2, so they didn't have much activity on the biopsy. Some did, and you're always going to miss a few people. Nothing's perfect. So you could say that. Okay. But I want to show you why this is important in the next minute. The other thing that I think is really important for you to understand is that patients with persistent proteinuria that would not qualify for a clinical complete remission, that you might have the tendency to keep on therapy for the rest of their lives, and remember, they should have a long life timeline, 63% of those patients actually had a complete histologic remission. So they had an activity index of 0. So how do you interpret this? First of all, we're really bad at correlating what we see clinically in the kidney, or using our current clinical tests, not novel biomarkers, et cetera, but just what we have clinically, with what's happening in the kidney parenchyma. Okay, that's number one. Number two, if a person has had sufficient disease that causes sufficient scarring, these patients will have residual proteinuria that's not due to ongoing inflammation. It's very common. We see it in all sorts of kidney diseases, and lupus is no exception. Those patients will never be able to reduce their proteinuria to what we consider a acceptable level, and then we're subjecting them to the possibility of lifelong immunosuppression. Okay? So the repeat biopsy could tell you that the patient still has activity, and if you saw a patient with activity that's in this range, you would say, maybe I better not stop immunosuppression. Or it could take a patient who you say, well, they're still proteinuric, they have grumbling disease, and you say, look, they have no histologic activity at all, maybe we could taper the immunosuppression. So I think this is a huge and a very controversial issue, so just so you understand this. This is a really cool study out of the Middle East. And the reason I'm showing it is mainly for this side of the graph. But these folks repeated the kidney biopsy about 12 to 18 months into the therapy. So the patient was beyond the very high immunosuppression of induction, and they were into the maintenance phase. And what they found, and why I think it's important, the activity indice levels that I showed you, is that the risk ratio for doubling of serum creatinine, and remember, in the nephrology world, doubling of serum creatinine is a harbinger of end-stage renal disease, and it's accepted by the FDA as a surrogate endpoint. The risk ratio for doubling of serum creatinine, I'm trying to find the pointer here, is 1.4 if the activity index at month 12 to 18 was 1 to 2, and it's 1.68, so 1.7 if the activity index was greater than 2. When they looked at the 10-year kidney survival, if the activity index on the repeat biopsy was 0, so no histologic activity, all of these patients had good kidney function. If the activity was 1 to 2, they did pretty well. 80% of them did not double their serum creatinine, but that means 20% did. Okay? If the activity index was greater than 2, so even a little bit of activity on that repeat biopsy, 44% of those patients survived. That means 56% of those patients doubled their serum creatinine and were destined to go on to end-stage renal disease. Okay, so I'm going to leave you with one last slide. This is sort of thought-provocative. This is something we're starting to adopt in our own practice. This is not standard of care. People will argue vehemently, including people in my own program who have vastly more experience than me, which is hard to believe since I'm getting so old, but they do. They're older than me, that this is silly, that we don't need a repeat biopsy. But I'm throwing this out there for you to think about because I like to be controversial. You suspect lupus, you perform a diagnostic biopsy, you give induction therapy followed by maintenance therapy, and then there's a whole bunch of possible outcomes. Let me just go down the yellow side. Partial clinical renal response. I just showed you that patients with partial response may actually be in histologic remission. So repeat biopsy at some point in their course may be useful in helping you get rid of immunosuppression. If they have a complete renal response, they can then flare, and if they flare, you're going to probably consider a repeat biopsy, and there's lots of things to think about here, but I don't have time to talk about it. Let's just go down the yellow brick road, as it will. A sustained complete response. At some point, you want to think about stopping therapy. You could rebiopsy that patient to verify histologic remission. If there's no histologic activity, you can stop the therapy. You don't stop it, you taper it, of course. And if there's activity, consider continuing the therapy. And with that, I'll stop and entertain questions. Thank you very much.